This is a case that was very kindly shared with me by Corey Georgesen, and I'm showing it using the Kiki platform. Now, I don't have the clinical information due to patient confidentiality issues, but I think it would be fair to say that the specimen could easily have come from somewhere around near to the mouth in an adult, and I think we'll use that as our background information. Now, these two pieces of tissue unfortunately don't have any epidermis, but we can tell they're from the skin because we can see follicular structures with sebaceous glands, and we can see that the specimen also includes some skeletal muscle fibers. Now, in addition, there's clearly a tumor present extending from the surface of the specimen right down into subcutaneous fat. So let's look at that a little bit closer. And I'll just straighten the specimen a little bit. Now, even at this magnification, we can make some useful observations. There are scattered keratocysts at the top of the specimen. We can even make out some glandular structures in the bottom of the specimen, and there's a dense fibroblastic stroma. So let's look at that a little bit more closely. And let's see, we can see the keratocysts fairly clearly. We can see that there are glandular structures, and we can see that there are narrow strands and lobules of tumor cells dotted throughout this sclerotic stroma. If we go in a bit closer, let's look at the top of the specimen, and there are our keratocysts over here. And then as we progress down the specimen, one can see evidence of duct formation scattered throughout. And in addition, we can see the epithelial strands, and this is perhaps best seen at high power, where there are narrow cords of cells surrounded by an incredibly dense stroma and small lobules of cells, as you see here. So, with that in mind, what would be the differential diagnosis? Well, I'm going to go back to this magnification here because this is quite useful. Now, keratocysts, narrow epithelial strands, one thought is microcystic adnexal carcinoma. A common differential is desmoplastic trichoepithelioma. Now, this cannot be desmoplastic trichoepithelioma for two big reasons. One, we know there's glandular differentiation. Well, you don't see that in desmoplastic trichoepithelioma. And secondly, the tumor is going down to subcutaneous fat, which is not a feature of that tumor either. So I think we can forget about desmoplastic trichoepithelioma. What other differentials could we think about? Well, we might wonder about ductal squamoid carcinoma. The problem with that diagnosis is the squamous epithelium appears quite bland and benign. There's nothing in the histology to suggest there's a malignant squamous component. It's just bland nests of squamous epithelium. And Dmitry Kazakov recently described an unusual tumor, which he didn't name, but it was a variant of squamous cell carcinoma, in which the squamous carcinoma was accompanied by a MAC-like background. And we've certainly got the MAC-like background, but we don't have any evidence of squamous carcinoma, so I think we can discount that. And so we're left with only one diagnosis that's really viable, and that's microcystic adnexal carcinoma. Now, the important thing to do with microcystic adnexal carcinoma is to search for perineural infiltration. And I've looked very carefully at both these pieces of tissue and cannot find any evidence of it. That doesn't mean it's not present, it just means that we haven't seen it yet. And in a case like this, I would examine levels and process the rest of the tissue if there's anything left in the specimen container, and look further. It's also quite useful to do an S100 protein because obviously that highlights the nerves, and sometimes it makes it much easier to pick up the perineural infiltration. In a case such as this, we're not really clear whether it's been fully excised or not, and this is one of the tumours that lends itself particularly to Mohs surgery in an effort to remove it with as much tissue sparing as possible. Some people suggest radiotherapy, but I'm not sure that's really necessarily a great plan for the primary treatment because it's likely to result in dense scarring, and then any residual tumor will become much more difficult to treat. So that's a fairly nice microcystic adnexal carcinoma. I hope this has been of some use to you. Thank you very much.